Commission will come to order. Fellow commissioners, included in your packets are copies of the minutes from our November 15th public meeting. I would like to entertain a motion to approve the minutes. Do I have a motion to approve the minutes? Move, second. All in favor, say aye. Any opposed? Thank you. All right. Commissioners, you have received in your packet for this meeting a series of written updates from our centers. You've had a chance to look at these updates. They're fairly extensive. Do you have any questions on the written updates? Do any commissioners have any questions at all on the updates? Does the executive director have any additional updates?
Thank you, Mr. Chairman. Yes, I have a couple updates. First, on some operational issues I wanted to bring you to your attention. Yesterday, we had our pre-bid meeting for recompetition for our Maryland Health Quality Performance work. This is a significant procurement. The proposals are due at the end of January. We hope we have a very curious and interested contractor group that will compete for this procurement. It's certainly one of our key priorities here at the Commission. So the RFPs will be returned to us. We will go through the review process and hope to have a contract in place by the end of the second quarter of 2019. We will be releasing a Healthcare Commission Strategic Priorities Report. We hope to make that public at the January meeting of the Commission. We will be circulating drafts to the Commissioners early in January to get your input on that. The priorities will lay out the issues that the Commission will focus on over the next 4 years and provide a guide for our work internally, as well as a basis for identifying how we'll be working with our colleagues in state government and stakeholders and residents across the state. So we'll look forward to completing that, getting Commissioner input, and then sharing it with the broad community of interested parties that we work with. I also had a couple of personnel announcements. First off, the state is always very appreciative of work that is done, especially those long-standing state employees that have served for many years. Recently, 2 of our employees, Linda Cole, if you could stand up, Linda, and Madeline DeSales. Madeline, are you here? Madeline may not be here, but Linda had just recently celebrated her 40th year with the state of Maryland. And Madeline had 35 years of service to the state. I'd also like to honor Madeline for the work she does. She is our representative for the Maryland Charity Campaign, and we have very comprehensive participation on the campaign, especially relative to other state agencies. And over the years, from time to time, people will call me and say, well, how do you do it? And I say, you need to get someone that's committed to it, like our staff person, Madeline DeSales is, and talk to her about how she does that. But it's a thankless job, but it's an important job. And without her, I'm sure that we wouldn't do quite as well as we do. But I really think it's important, although many of us have other charities that we care about, the fact that the commission staff largely contributes in large and small ways to something we do in common is very important. And I want to thank Madeline for that work because we don't get a lot of volunteers to take that on. Lastly, it's my responsibility today to also let you know that my executive assistant, Diane Arnold, will be retiring after 35 years of service with the Healthcare Commission. I think it says a lot when I say that Diane served 3 executive directors, Barbara McLean, Rex Cowdery, and now me. And when I became executive director, both of those people called me to say, trust Diane, she's going to help you. And I was at least initially worried, well, maybe they're just planning for her to text them back and tell them when I'm screwing up, but that turned out not to be the case. There are 3 characteristics I think that Diane really possessed and made her a great colleague and assistant. One is tremendously good in judgment. If there are things I would do that she had questions about, she wouldn't say this oftentimes directly, but she would say, you know, Rex would do it a little differently. And often she was exactly right, that her ability to caution me was usually spot on. And that carried across the entire organization because I know that many people look to Diane for their good judgment. Diane had tremendous initiative, and it wasn't often that I had to ask her. The jobs that she took on here were sometimes things that were very important, but no one else wanted to do. Over the years, she worked on, took on responsibility for legislation. She was one of the unspoken truths here is staff aren't real enthusiastic about taking minutes. And over the last 7 or 8 years, maybe longer, Diane has done that and done that very well. But there was no task too small or too insignificant for Diane to volunteer without asking to take this on. And lastly, a tremendous amount of respect. I think commissioners always, when you contacted Diane, got enormous helpfulness and respect. But I suspect that everyone says, well, you know, I'm a commissioner. I wonder how this person or that person is with a comment, with just someone calling up. And I always saw Diane, regardless of who the person was, be respectful to that person, be helpful. And that's enormously important to me. And to see it in a devoted staff person was really touched me. The thing I'll remember about Diane was, as she signed some funny things, is in 2013, as many of you remember, we had a major healthcare reform, and people didn't really know where to go to enroll in health insurance. And some people showed up here, even though we were not directly involved in the enrollment in the ACA. But you know, we could have just shooed them away. I remember Diane out front holding the door open for a couple people to come in, even though there was nothing we could do. She at least wanted, you know, to give them a chance to be guided in some way, being told where to go. So those are important values for the entire organization, and Diane conveyed that. She has a long history here from the very birth of MHCC. As I told the staff on Wednesday, if we were giving away medals, she would have a whole chest full of banners, campaign ribbons, and honors from the formation of MHCC to finally the creation of the freestanding medical facility legislation. She was there for all of the major issues, major policy questions. So she really knows the history of the place. And I certainly think when the history of the MACC is written, there's going to be a chapter written about Diane Arnold. So I want to thank you for your service. I would like to say we have not seen the last of you. I hope that's true, but it's in a party mode, not in a work mode. Best of luck to you, and as Secretary Neal observed recently, we must have not enforced the child labor laws when you first came to work here, because you look so young as you're retiring from the state. So thank you very much.
Diane, if you want to say something, please do. Thank you, Diane. Any other directors, center directors have any additional updates? Megan?
So I just want to introduce a new staff person. I want to welcome LaWanda Edwards. Can you stand up? LaWanda is joining us as a program manager, and she'll be working closely with me on communication, stakeholder engagement, and policy. She has an extensive career in communications journalism and community and government affairs, and she's deeply knowledgeable about Maryland and has worked in other agencies in the state, and we're very excited to have her join the team.
That's great. Welcome aboard. Any further updates? Any of the center directors? Anything? Okay. Before we consider actions today, action items, I want to remind the commissioners that if you feel that you have a conflict of interest or an appearance of a conflict of interest and you wish to recuse yourself, please do so and move yourself to the commission conference room. The staff will let you know as soon as the commission has completed action on the agenda item in question. Okay, so everybody be aware of that. Okay. All right, now we are going to conduct a brief hearing on the modernization of the Maryland Certificate of Need program. Over the past 12 months, the commission convened a task force to study the modernization of the state health plan and the certificate of need process to identify what was no longer needed in that process, and to align our program with the development of the total cost of care demonstration that we have entered into, as well as the more general evolution of a rapidly changing healthcare delivery system. In June, we issued an interim report that identified a number of problems with the current process. That report sparked a spirited discussion in the task force on potential solutions. On December 3rd, the task force completed its work and submitted a draft report to us containing the recommendations that the commission could complete under its own authority. These are administrative actions by the commission that we can do independently of legislation. Also, they suggested recommendations that would require legislative action. And finally, there were a group of recommendations that should be considered, but would require, in the view of the task force, further engagement with other state agencies and interested parties. Throughout the process, and it was an extensive process, the task force chair, Randy Sargent, along with Commissioners Metz and Hafey and O'Grady, encouraged stakeholders to offer suggestions and make recommendations on their own, comment on those that were under consideration. Commissioner Sargent also asked that stakeholder comments be offered for the draft report that we're considering today. All of you have received in your packages the comment letters. So you have a very clear idea in black and white of what indeed the stakeholders have been saying. We want to ensure that all the commissioners have a full range of understanding of what is in the report and how the stakeholders are responding to it. And that's why I've decided to allow individuals to speak today at our meeting. As I say, this is not going to be like a congressional hearing that will go on for 3 or 4 hours. Nobody's going under oath either. Nobody has to worry about taking the Fifth Amendment. None of that's necessary. But we would ask the commenters to speak for about 5 minutes. If you can make it shorter, that would be fine. And after each speaker, if members of the commission feel compelled to ask a very specific question that will add to the sum total of human knowledge on the subject, please raise your hand and we'll be recognized. We're going to hear from 6 commentators today. Joseph D'Amatos, President of the Healthcare Facilities Association of Maryland. Dana Kaufman, who is representing Lifespan Products and Services. Richard Priziwara, who is the Senior Vice President for Operations at Ashley Treatments. Peggy Funk, Executive Director of the Hospice and Palliative Care Network of Maryland. Brett McCone, Vice President for the Maryland Hospital Association. And finally, Patricia O'Connor, who is she is an Assistant Attorney General representing the Attorney General's office. So we'll start with Mr. D'Amatos. Mr. D'Amatos, thank you very much for coming this afternoon. We welcome you.
Thank you so much, Mr. Chairman. I appreciate the opportunity to comment. And I just want to thank all of the commissioners for the work that you're doing on this important subject and on the modernization of state health plan. We've actually spent a great deal of time together with Commissioner Sargent, the task force, and we appreciate your leadership of it, genuinely. I think it's important to stake out at the beginning that while we may have differences of opinion on or positions going forward, I think we have a shared interest and we're in the right place to get it right. I really want to just bring up a couple of points today and really use examples from my recent experience over the last 3 or 4 or 5 days, including this morning. So the Health Facilities Association of Maryland represents the majority of what you all call CCS, or Skilled Nursing and Rehab Centers in Maryland. Together, our members provide over 6 million days of care a year to Marylanders in need. Over 4 million days of care on Medicaid, 1 million days of care in Medicare, and a total of 6 million days of care across all payer sources. And I bring that up in terms of the total cost of care. The reality is that in Maryland, with the total cost of care and with birth rate demographics, that folks that used to go to a skilled nursing and rehab center for care after an acute stay, rehab before they go home, many of those folks aren't going to skilled nursing and rehab centers anymore. The folks that are going to skilled and rehab centers now are the folks that have had an acute hospital stay but are medically complicated. Maybe they're bariatric patients, or they've had strokes or heart attacks, or they've had something done for it, though. Let's say they're at risk of an infection. So I guess the first point I would make is that really today's CCFs are not the CCFs of even 5 or 6 years ago. And the fact is that volume is actually down. Length of stay is slightly up because of the clinical acuity of the patients. And I think that's important for you to consider. Second point is the point from going to the monthly Department of Health nursing liaison meeting this morning, where the department shared their preliminary data on occupancy. Now, it's preliminary and it's not weighted, but this is their preliminary data. About 86% occupancy, total occupancy in Maryland, skilled nursing and rehab centers, and about 65% on Medicaid. Now, when they weigh those, it'll go up. So I suspect that total occupancy will be slightly under 90%, and Medicaid occupancy will be closer to 70%. So why is that important for the discussion today? The 2 points we've been making consistently with regard to the modernization. With regard to the Memorandum of Understanding, Lifespan, the Department of Health, and HFAM are all in alignment that we need the Memorandum of Understanding to ensure that there's access for care for Medicare and Medicaid patients. But what's proposed in the modernization is solving a problem that doesn't exist. there's no backlog of people on Medicaid in Maryland trying to get into a skilled nursing and rehab center. Occupancy is going to turn out to be, when the final report comes in from the Department of Health, be slightly less than 90%. And Medicaid occupancy is going to be between 68 and 70%. That's the first point. The last point I want to make is having to do with the really historic proposed exception to docket an application to build a new skilled nursing and rehab center relative to the total cost of care. There seems to be somehow a disconnect that believes that skilled nursing and rehab centers in Maryland today are not innovating with their hospital partners. And while innovation is not yet systemic because of where we are in the total cost of care contract, there's tremendous innovation. And I just want to touch on 5 things in my last minute and a half or so. This week I was at Genesis Franklin Square Skilled Nursing and Rehab Center, where the nursing home actually has a nurse practitioner in the hospital that's an employee of the nursing home. And where, in addition to their attending physician and their physician services practice, which they own, they contract with a MedStar physician to do geriatric rounds in the skilled nursing and rehab center. That's one point. Secondly, Future Care downtown in Canton and their vital strong partnership with Johns Hopkins and their rehab program. Thirdly, Communicare and their partnership and the work that they do with LifeBridge on behavioral health and communications issues. And then finally, I was this week twice in ManorCare centers that are in the DC orbit, sort of the Montgomery County area, that are doing partnership with hospitals there on complex cardiac rehabilitation. So the last point I will make is that is why we've been so strongly opposed to those 2 issues of including the memorandum of understanding under the current concept and allowing skilled nursing and rehab centers for the first time in Maryland history to be built absent bed need because of work on the total cost of care. Thank you, Mr. Chairman.
Okay, thank you very, very much. Are there any commissioners who have a question for Mr. D'Amato? Anybody?
Genuine thanks.
Thank you very, very much. We'll next hear from Dana Kaufman, representing Lifespan Products and Services. Welcome, Dana.
Thank you. Thank you, Chairman, members of the committee. My name is Dana Kaufman. I'm here on behalf of Lifespan Network, and I'm with the law firm of Schwartz, Metz & Wise. You have my written comments, so I will not go too deeply into those, but I do want to point out or emphasize a few points that were contained in those comments. And I also want to point out that unlike the other industries that are affected by the CON modernization, the nursing facilities are already under changes that you have proposed under the state health plan. Those revisions were printed in the Maryland Registry on December 7th, and you'll be receiving our comment. Why that is important is because many of the issues that were presented during the CON Modernization Task Force also were placed into the state health plan, or basically on a path for approval right now if that continues. So a couple of those issues. So for us, it was actually it was interesting because much of the language that's in the CON Modernization report is a bit on the vague side, but for us, we were able to see a little bit more of the practicalities from the state health plan. So for the 2 issues that I really want to bring to your attention is the one recommendation that's under immediate relief that would allow the authority for the commission to docket an application or to waive other considerations for a CON if the project is within or approved by the HSCRC under total cost of care. We oppose that measure, frankly. We think it's premature. I have to be honest, and I have a more detailed analysis, but I think that you still need statutory authority. So to have that under immediate is confusing to me. And frankly, in your October matrix, you also indicated the commission that you needed statutory authority. So I find it hard to understand why it's under immediate. More importantly, what that recommendation will do is it will allow the addition of a new bed or a new service regardless of need. And that's where our issue really lies. The fact that you can allow for new nursing home beds to be developed under the auspice of total cost of care at a time when the total cost of care program hasn't actually taken effect. It takes effect January 1st, 2019. Lifespan serves on the State Innovation Work Group, or the Stakeholder Innovation Group, that is looking at the design of additional programs that will be under the total cost of care. So to allow right now to move forward on the ability to waive a project when the parameters have not been designed is troubling to us. And on that, we would then recommend that it be moved from the immediate recommendations over to further study until those details can be worked out. The second issue that I wanted to bring up is also contained in the state health plan. It wasn't under your recommendations, but it is contained as a recommendation under the matrix in the earlier part of the report under comprehensive care facilities, and that deals with the quality metrics. The state health plan uses the 5-star rating system, and we have always had a concern about the 5-star rating system being used as the quality metrics, especially when it's the only quality metrics that is cited in the state health plan, which again crosses over to the CON modernization report. The state actually in itself had an issue with that, and that is the reason we created the Maryland Pay for Performance program, which truly does more fairly report on the progress and the quality in Maryland's nursing homes. Our recommendation is that the Pay for Performance program should also be part of the quality indicators that are used in any decision for a certificate of need. So again, those points I wanted to emphasize, and they are contained in further detail in our letter. Thank you.
Thank you very much, Dana. Commissioners, does anybody have any questions for Dana Kaufman? Yes, Commissioner Metz.
Thank you, Dana. Could you briefly explain the statutory change that would be necessary to the commission, as you mentioned, as far as the section of expanding CON access?
Sure, because the ability to waive a docketing or eventually the approval for a CON, it's being put in the immediate relief, but you have a statutory basis for when you want to add new beds or change a service. So in order to do that, you would need to add new beds under that auspice. You would need a statutory change, in my opinion. And what I do find very ironic is that appeared to be the opinion of the commission in the October matrix that was presented. In that matrix, there was 5 or 6 different items. One was exempting or allowing for the docketing of a case due to the if quality measures were not satisfied. The other one was docketing, allowing the docketing of a case if it or an application if it aligned with the total cost of care. The statutory need still exists for docketing for quality issues, but it no longer exists for total cost of care. I don't understand how you can need statutory authority to docket one and not the other. So that is the issue that I have. And if that's the case, then it shouldn't be under immediate. It should be under further study.
Any further questions? Thank you very much, Ms. Kaufman. Really appreciate it. The next spokesman is Mr. Richard Prisvara. Prisvara. I'm sorry, sir. Okay.
I think you're the first person to mispronounce that.
Oh, I'm sure. I'm shocked. You're the Senior Vice President for Operations at Ashley Treatments.
I am.
I just want to say to you personally that I'm familiar with what you do out there, and the record is tremendous, and the help you've given people is really outstanding. So I'm very familiar with your institution.
Thank you, Mr. Chairman and members of the Commission. I will say that it has been an interesting and enlightening process to be part of the modernization review. And in our position from Ashley, there are quite a few things that we agree with. We understand from the staff's position that it has been difficult at times for providers to come in and work through the CON. We went through that process prior to my arrival, and I talked to the staff at length, and I think the components we made which were to remove the business reviews and the finance reviews and the building reviews and the cash flow reviews, really should make the CON process accessible to organizations. I will not reread my letter, which we addressed a few issues in here, but I do want to share with you that as I looked at the premise for the Commission's work, it seems like there may be a somewhat of a basic misunderstanding of issues facing treatment in drug and alcohol. Unlike other components of healthcare in Maryland, there's a difficult, unhealthy side to drug and alcohol treatment and patient brokering, and with companies that come in and prey on people that are suffering in the area of substance abuse, primarily to get insurance payments. We're seeing this in Florida and California, where patients are being recycled. They're picked up at one treatment center, and based on their insurance that they carry, they're intoxicated and driven to another treatment center. And that broker is paid a commission by delivering a patient. You don't get that in other parts of healthcare in the systems. No one is leaving a breast cancer treatment and driving to another facility to start breast cancer treatment again. There's no opportunity for patient brokering in a lot of our healthcare. This is an area, unfortunately, that is more prevalent than we'd like to admit. I think it is important, and I strongly resisted the elimination of the CON in any fashion until there's a strong equivalent replacement process for it. It's clear that the CON is not drug and alcohol is not your primary area in the Healthcare Commission. I understand that, but the impact on individuals is dramatic. I suggested to Randy and the staff that they reach out to their peers in Florida and California. I don't know if that's happened, to understand what happened when they made changes. I personally talked to the Assistant U.S. Attorney in Florida to get her perspective from the enforcement end. What happened? What went wrong? And what Kristen shared with me was, as soon as you deregulated under the auspices of providing more treatment avenues, making treatment more accessible, lowering the cost of care, you immediately attracted the predators in the industry. They came in, they meet the minimum requirements, they begin billing the insurance companies, and they begin sharing patients to each other. As soon as you're done your 25 or 22 days, whatever utilization authorization you can get, you're shipped to another facility. You show up intoxicated under your drug of choice so you can be admitted at the next facility, and the person walks away with their payment. That's what will happen in Maryland, she was sure. It was very interesting. She had some other comments to me about the industry that we should take a look at. But it was very clear that attempts to make the market more accessible by lowering regulation are going to invite in the predators. They're waiting for a new market. They're there, they exist, they know what happens, and they know how to go in and do this business. And so it'll be very easy for them to come in, I think, and take advantage of Marylanders, which will not help them get better. Really, a stay at Ashley is the beginning of recovery. It's not, no one is finished the day they discharge. It's part of a process. So we think it's very important that the Commission look at that recommendation. We'd volunteer to be part of a process that looks at what we would do instead. I don't think that to say that the process is too complex is realistic. If you're going to care for patients who could die in your care, the fact that you're unable to process an application means you're unable to provide the care to those patients that you should be doing. Because you're dealing with doctors and nurses and clinicians on developing treatment plans. That's far more complicated than the actual CON application. I do agree that it was complex and many people needed consultants to do it. I think the changes that were done are significant. It should make the current process manageable for new applicants who want to come in and provide treatment of care that you expect them to provide in the state of Maryland. So there are several points in our letter that we think you should take a look at. I was puzzled by one minor component, which is the reference to people in treatment for drug and alcohol as customers rather than patients. Healthcare Commission deals with patients, but it was only this area of care that you referred to our participants in care as customers. I think that's just a little bit of a focus on how perhaps misunderstood the treatment is. They're not customers, they're patients. They come in with significant health issues, patients die in care. It is just as important to provide the competent medical care as it is in other facilities in Maryland. So I think that the objective of making Marylanders safe is important, and I think these modifications do the job. I don't think you need to eliminate anything without a solid replacement in place. So I'm not sure where we stood on whether this was going to be in the short term to remove or whether we were going to remove it when we had an alternative in place. So that's our position today. I don't know if you had any particular questions.
Are there any questions? Any questions? Thank you very much, sir. It's a pleasure having you. The next spokesman is Peggy Funk, Executive Director of Hospice and Palliative Care Network of Maryland. Funk, welcome.
Thank you, and good afternoon, Mr. Chairman and members. Thank you for having us all here today. And I'd also like to thank the work group that talked about the CON modernization. Our members had the opportunity to actually thoroughly review the report, and we have submitted our comment letter, which you have before you, that's dated December 12th. So we, like many other organizations, have had some issues or challenges, I will say, with this report. But basically, if you look at what our letter says, you know, we agree that there are changes that need to be made and some modifications. But there are a few points I do want to make that I think are important and that we would like you to reconsider. The first one talks about the updating the state health plan. And while we can agree with your bullets A and B, C is a problem for us, just that we find, like many others have stated, that the language in there seems to be a little bit vague, and it really does lack transparency. We feel also, like others have mentioned, that it's really important to understand the operations of these post-acute providers, especially hospice, because many of our providers are nonprofit, but at the same time, they're extremely innovative, and they are right now, with the exception of a few jurisdictions, meeting the needs of patients. To start bringing in a huge amount of other providers is simply going to put a really heavy burden on them that will not just affect how they operate, but it actually will affect quality of care because those dollars just aren't going to be available. The other point that we wanted to make, and I have noticed, is that, and I think I did mention again that need it's very important to take into consideration. So we are concerned that if you take away, you know, if you allow the HSCRC to just, you know, make that decision on its own, that again, as I believe Dana Kaufman very well stated, the total cost of care program has not gone into effect at this time, so no one really knows what the ramifications are going to be. We don't know the amount of money that it's going to save or if it's even going to be successful. And finally, I just want to leave you with a few thoughts about the CON and what eliminating the CON will not do. So to eliminate the CON does not provide savings for taxpayers or patients. It doesn't create a free market environment for hospice to operate. It does not increase needed services back to the community or increase quality care for dying patients and their families. Eliminating will not protect patients and families from being harmed. And lastly, eliminating the CON does not reduce the size of government. So those are my comments, and I thank you for the opportunity.
Thank you very much, Ms. Funk. Are there any questions for Peggy Funk? Thank you very, very much. Our next spokesman is Mr. Brett McCone, Vice President of the Maryland Hospital Association.
Thank you, Mr. Chairman, Commissioners. Brett McCone, Maryland Hospital Association. First and foremost, I'd like to thank the task force's leadership during this process. Certainly, Commissioner Sargent, somewhere between peace in the Middle East and revising the cardiac surgery chapter of the state health plan, with strong and varied opinions, and he navigated that very well, along with former Commissioner Phillips. Also would like to thank the staff, meticulous preparations of material, thorough organization, and restraint to allow stakeholders to develop recommendations. It's always a pleasure working with the staff, and this process was no exception. Next, the final report. You've received the association's comments, so rather than regurgitating that letter, I'll offer some color commentary. MHA, we began a process back in 2015 by convening hospital CEOs and health system executives for a round of sort of directional recommendations. And we came out of that with the following: that CON is needed to ensure access to high quality, efficient services. We need better links to Maryland's all-payer model. All healthcare providers are responsible for that model's success, and of course the application process in itself needs to be improved. We then reconvened. We brought it down a level, 2017 to 2018, with representatives from hospital finance, operations, government affairs, and planning. And our conclusions there, reflected in our letter and our comments before the work group, were that CON and the state health plan are important policy levers to provide the appropriate supply of quality services needed to support model outcomes. We support the regulatory focus areas, including right sizing capacity. We need to fix the application process, and the Sister Commission needs a new capital funding process. And I'll hopefully have a chance to repeat that conversation with that commission in this very room. And as we get started on our just my comments briefly, I would remind the commissioners that Maryland's hospitals are the only ones from a revenue standpoint that can be held wholly accountable for the outcomes of the model. I would agree with Mr. D'Amatos that all healthcare providers were all in this together, but the state only has one lever at the end of the day to ratchet down hospital prices if needed to be successful. So just thoughts and brief comments on the reform. And we sent a letter in on the final report. We also sent in a very detailed letter back in September that had very specific recommendations to regulations and to statutes. But a couple quick points. First, the commission should set the direction for the agency. And we think, a big part of that would be just assessing each chapter of the state health plan on an annual basis. Not necessarily a full-blown review at that level, but look at each chapter. And then at a public meeting decide, we think these 2 or 3 chapters are the ones that need the priority review, and then direct staff at that point to move forward with that. Let's do that once a year, and let's do it at a public meeting. We completely agree that the application process needs to be pared down. Others around the task force heard me say it's time to clean out the garage, so to speak, that we've bolted a lot of things on to this over the years. So let's focus on what's important to make a decision. And at the same time as we do that, then we talked about there's a proposal about creating an abbreviated process. Well, if we pare down the approach, then we may not need an abbreviated process. I think we just have to look at that sort of in parallel. We ought to discuss would recommend that the commissioners discuss the status of all applications just for a few minutes at every public meeting, just so the commissioners are aware of what's out there and where it stands in the process. And we completely agree with staff that we need to get this done on time. If it's uncontested and there are no service changes, there's absolutely no reason it shouldn't be done in 120 days. And without giving staff and council a heart attack, it can probably be done even faster than that. With regard to the HSCRC, the specific comment in there, we agree that the agencies should work closely together. We don't support the proposal to waive certain CON requirements. There's just too much subjectivity in that. And as the hospital's having to deal with the commission, I think we all agree that total cost of care is important, but we're concerned about the HSCRC usurping this commission's authority. In the statutes, we think there's one key recommendation missing, and that is I think we need to add some specific language in the statutes to explicitly link certificate of need and the state health plan to the total cost of care model. We think that future CON decisions in the state health plan should align with the model. It's a small step to put that language in there, but we believe that's a very important step to set that guidance. We agree that we need to change the threshold. We are recommending that for hospitals at least, the threshold otherwise for no other statutory reasons should be 25% of a hospital's annual revenue or $50 million. whichever is lesser. We just believe there needs to be some limit there. We agree on the CON the statutory considerations on the requirements. There's lots of detail that needs to be worked out with that, but we certainly appreciate the approach. We don't support the recommendations to eliminate CON approval for certain services, including psychiatry. As reflected in our letter, we think the prudent approach here is let's look at certain chapters of the state health plan. Immediately, let's look at the psychiatry chapter of the state health plan. I think concurrently, with the drug and alcohol treatment facilities. We need a real assessment to understand what the supply of services that is there, what the demand for certain services is, including subspecialties, I think before we make that recommendation. And then we can call the ball after that. We certainly support the study areas. I think the gatekeeper function is an important one. I've used the analogy that the CON is a building permit, and you're going through this process and, only the one time that you have it. And are there other opportunities, whether that's through licensure or through quality monitoring or other, areas where that can be, if there's any ongoing enforcement of things with healthcare providers that need to be addressed. Just to summarize, I think we're largely supportive of the Commission's draft recommendations, certainly respect the need and wholeheartedly support to address the approval process and, like I said, clean out the garage. Critical needs are to include the model alignment language and prioritize the state health plan review. I can't thank Commissioner Sargent, former Commissioner Phillips, all the other commissioners that participated in the staff enough. Very well thought out, very well organized process. And please, I'm happy to answer any of your questions.
Yes. So please, let's have any questions. Anybody have a question specifically? Yes. Mr. Director.
So, thank you for your comments. You didn't touch on the ambulatory surgery recommendations directly, I don't think. I wondered if you had, MHA had a perspective on those. They specifically would address basically creating some parity in who would be eligible for expanding facilities below 2 ORs. Did you?
Yeah, and good point. In our comment letter, the recommendations are consistent with what the changes were last year to the ambulatory surgery facilities chapter, in defining the, consistent in definition of the 2-room. Now you can get 2 instead of 1 through an exemption process. So we think that's consistent. And we agree with the recommendation that allows hospitals and other providers to establish up to a 2-room ASF, through the exemption process, rather than limit that process to, what was deemed a group of physicians. So, I think we're supportive of those 2 recommendations. It's consistent with what you did last year with the chapter.
Okay. Any further questions? Commissioner Sargent.
And it may not be a question. Thank you for your input. One point about the hospital submission that's a little different from the others, and Mr. McCone referred to it, was they added a number of suggestions about review of the state health plan and timing. And we did not add those to the report because they came in a little late in the process. We hadn't evaluated, but they are within our control. And I'd suggest to the commission, we can look at those and we can still consider them without adding them to the report, because that part is within the control of the commission.
Okay. Mr. McCone, as always, thank you very much. Have a great day. And finally, we're going to hear from Patricia O'Connor, Assistant Attorney General, representing the Office of the Attorney General.
Thank you, Mr. Chair, Commissioners. We appreciate the opportunity to weigh in on this important effort, and we thank you for the work that has gone into this. The Health Education Advocacy Unit has a statutory mandate to speak for consumers on healthcare issues that will affect them directly or indirectly. Of all of the topics that have been addressed by you in the work group, in your draft recommendations, and by other speakers here today, the one topic that has gotten our attention relates to the need for more affordable and accessible and effective drug and alcohol treatment centers. The HEAU has a hotline, and we intake complaints and handle thousands of calls and complaints from consumers annually. So many of these complaints touch on the lack of access, the lack of the ability to afford this care. So we're acutely aware of the public's desire for better services that they can afford. Our concern, however, is that the history of these providers and the industry generally in other states that have relaxed some of the entry requirements and that have a lenient or non-existent regulatory scheme, that history is bad and involves harm, often fatal harm to consumers. So we support and thank you for the recommendation that you are making that there be further study with the Maryland Department of Health involving the MHCC and its staffers who have expertise on the threshold issue of whether an applicant in this area is a good actor or a bad actor. So we see two very important points in this process. How will it be most effective for the Maryland Department of Health, most likely through BHA, the Behavioral Health Administration, to do that threshold evaluation of providers who want to provide these services in a different way and in a different format. It certainly seems that sober homes and outpatient services, when provided properly and with the proper safeguards, are effective and assist consumers with addictions who are entering recovery and are seeking to maintain their recovery. The other pressure point, though, has to do with monitoring the activity in these facilities and by these providers once they are in our market. And it does seem to be an area where especially vulnerable people may be exploited and may be harmed. So we would hope that the investigative expertise that MHCC staff has acquired as part of its vetting of applicants for the CON process can be shared with those who are more likely. It is likely that BHA, I mean, depending on how it all evolves, but that does appear to be a logical place for these activities to be transferred. We would ask on behalf of consumers that great care be taken, though, because we need to be sure that the applicants are properly vetted and that once they're in the market, they are properly regulated. A final point that I'd like to make regards charity care. And on behalf of consumers, we respectfully ask that the Commission's current regulations relating to charity care be maintained. We think it's vitally important for those who can't afford care, and we tend to hear a lot from those consumers. And we think the informal process that is set forth in your charity care regulation is what is required. Within 2 business days of a request, the consumer is supposed to be given a determination regarding probable eligibility for the charity care or the reduced rate. And while there are later opportunities to verify what the consumer says regarding his or her need, we think it's really important that the process not be bogged down with barriers relating to onerous or at least burdensome documentation requirements. We think it's a really good regulation. It benefits people, and we ask that it's not.
Thank you very much, Ms. O'Connor. Do we have any questions for Assistant Attorney General O'Connor? Yes, Commissioner Thomas.
I want to ask you about the bad actors. Since you know about them, they're known, what keeps them around? Why do they thrive? And how can we not have countermeasures to ensure they don't thrive here?
So I wish I could answer that based on facts, but our current system seems to have kept them out of Maryland so far, so that I'm not really aware of factual examples in our state, which are like the examples that I imagine you all have heard about or perhaps read about in California and Florida. And that is a good thing. And we don't want to have that personal experience here in Maryland. A related topic that may be of interest to you would be some of the investigations that the Medicaid fraud unit in the Office of the Attorney General investigates and prosecutes. And you have analogous bad activity in that setting where you have licensees who either enter healthcare intending to act corruptly or for whatever reason, once in the field, begin to act corruptly. And there are, so those are billing, those are typically billing errors, right? Or corrupt billing practices. In that field, there are software programs that have greatly assisted the state and the federal government, and we often cooperate in these prosecutions because where there's Medicaid fraud, you will have, more likely than not, Medicare fraud. So you can do with billing some screening, it assists with the investigation. In drug and alcohol treatment, you're dealing with many points of care that are not documented and that are not strictly billing problems. They're more profoundly corrupt in that individuals who lack the ability to protect themselves because they're cognitively impaired are physically exploited, physically harmed. So you have that activity, which is honestly much more concerning to us than the billing activity, which is deeply concerning to us. So all of this, I would say, points to the need to prevent and to screen and to monitor.
Thank you.
Mm-hmm.
Director?
Just one question on, probably the commissioners have not heard this, and I don't mean to surprise you, but in terms of the your unit, where does the bulk of the complaints actually come from? Are you getting complaints from home health agencies or drug treatment facilities, or where did the bulk of the complaints come to from your vantage point?
So it's the consumers themselves. It's typically family members. And so the sectors are, and I'll look at this more closely then and try to get back to you with more specifics, but I would say, based on my day-to-day, the questions that get elevated to me from the hotline and then from the daily complaint. Nursing homes, we don't.
Policy is like,
excuse me, someone's on the line. If you could mute your phone.
like whatever, gets to the targeted populations, right? So we showed like a bunch of newspaper ads for Laurel FMS. So
we had to clean up because nobody was doing it.
not right.
Yeah.
So I want to make sure I'm not
you're coming through loud and clear.
If you can talk a little louder, I can't hear.
Oh, yes.
So elder care, nursing homes, the independent boarding homes, home health, then that's really, it's elder care, really. For the drug and alcohol treatment, more often than not, it's just that they can't afford it. The carrier won't pay for it. There's not anything within a reasonable drive so that they can take care of their other obligations, such as caring for children, et cetera, et cetera.
That's helpful. Thank you.
Yeah.
Thank you very much.
Mr. Chair,
Yes.
only because we're talking about this degree of human suffering.
Mm-hmm.
So now it's on the consumer, in a sense, of witnessing, the family member witnessing, therefore see something, say something. Well, when you see it, who do you call? When you see that elderly person left on the corner of a bus stop at 30 degrees?
Excellent question. They often,
who do you call?
So often they call us.
And who's us?
And we are the Consumer Protection Division, and in Maryland, it's within the Office of the Attorney General.
I just met you for the first time. I would have no idea that I should call you.
So we do outreach, and our outreach coordinator is really targeting seniors and other vulnerable communities. And I'd be happy to provide you more information about our unit. And we often serve an air traffic controller function. We get many calls from consumers who are actually calling about a licensee problem, a regulatory problem with the hospital. So we will refer to and coordinate with other state agencies, particularly when there's urgency. And whenever there's a risk of harm or there has been harm, we all work and coordinate carefully. But you touch on a point that is vitally important to us. The Attorney General often seeks to spread the message about the Health Education Advocacy Unit and consumer protection generally. And I'll be happy to speak to anyone offline who has more questions about that.
Thank you very much, Mr. Clark.
Thank you.
Thank you. Okay. Ladies and gentlemen, now we will hear from Commissioner Sargent and Mr. Parker Paul Parker on the final report recommendations. As we previously noted, the CON Modernization Task Force met on December 3rd to consider the recommendations for the final draft report. This report was requested directly by the Maryland Senate Finance Committee and the Maryland House Government Operations Committee, and we are charged with delivering that report to them very soon. So at the conclusion of their presentation, the commissioners will then consider action on the report. Commissioner Sargent, Mr. Parker, the floor is yours.
Thank you. I'm going to start by thanking my fellow commissioners on the task force, Commissioner Stacey, O'Grady, and Metz for their help, and also the rest of the task force. It was a very good and robust discussion. I think we have a good, solid set of recommendations, and well, you know, different folks have different concerns, but that's to be expected in my view. We have a number of slides that I'll go through quickly because there isn't anything in here that you haven't seen before. We've been trying to come and make sure that the commission is able to follow along as it develops so that it's not a big surprise at the end. And I think we've managed to achieve that goal. Hopefully the commission feels that we've achieved that goal. Since it's you, but that would be the ones that would be surprised. So the charge to us was to examine the major policy issues, include a review of other state approaches, recommend revisions to the statute, recommend revisions to the health plan regulations, consider the flexibility needed to streamline the process, and identify areas of regulatory duplication. This is just a list of the state health plan regulation sections that govern the facility planning. If you look on the asterisk, that's the plan that's been updated in the last 3 years. The ones that do not have an asterisk have not been updated within the last 3 years. We didn't go section by section with recommendations to the state health plan because these recommendations are at a high level. So as we see when we get to some of the recommendations, there is some uncertainty in some of the recommendations at this level because we will need to adopt regulations to implement them, and we will need to address that uncertainty at that time. So today, there's 6 basic criteria, right? Application has to be consistent with the state health plan standards for the section under which it falls. It has to be need. There needs to be an availability. We look at the availability of more cost-effective alternatives. We look at the viability of the proposal in terms of the resources and whether the project is implementable. We look at the compliance with conditions of previous certificates of need, and we looked at the impact on existing providers in the healthcare delivery system. And I think those of you who have been commissioners assigned to be the reviewer on a case, we spend a lot of time talking about impact on existing providers because that's where you have interveners show up. The Modernization Task Force, we've seen this before, we won't have much time on the slide. Just thank you again to all the folks listed here. We talked about the chair talked about the calendar. I don't think we need to stay on this slide. The guiding principles to keep in mind the task force developed these at the beginning of phase 2 after we had listed off the problems and we put down the principles for how we're going to solve them. And they're sort of the basic things we want CON to do and to not do. And we want to promote the availability of general hospital and long-term care services and appropriate availability of specialized services. We want to complement the goals and objectives of the total cost of care model. We want to provide opportunities for innovators to enter the market when they're committed to the delivery of affordable, safe, and high-quality care. We want to minimize the regulatory requirements to expand existing capacity, reduce the burden of complying with CON, and maintain meaningful review criteria and standards. And if I'm going too fast, please slow me down. You don't need me to read that's one of the words. You know, the principles, those are sort of, it's the balancing of those principles where the rub is. There's no one of those principles that you would object to necessarily, right? So the common themes that we heard in the first phase is what we addressed in the regulations is most of the regulated facilities, as you can see from some of the commenters, see a need for CON regulation in some form. There was more support for keeping CON in the abstract than for eliminating it. The substantive discussion, or there was a good deal of substantive discussion about the appropriateness of the current scope and currently regulatory process. And I would add to that, as you can see from some of the comments, there's a good deal of discussion as, is it really CON that people want? Because if you're only looking at some aspects, such as who the person applying is, you're not really getting a certificate of need. You're doing something else that maybe should be under a different regulatory structure. Then CON regulation shapes the healthcare system today, right? So we need to sort of recognize that as we're changing, it's not a purely abstract question. It's a question of how we are affecting existing businesses and the existing structure of the market. Next slide. The supporters of CON saw a benefit in reducing overcapacity, facilitating more equitable access to care, more appropriate care, and reducing opportunities for fraud and the potential for overwhelming oversight capacity of licensing and certification agencies and labor shortages. Some supporters also saw limits on growth and new market entry as beneficial in protecting expensive investments in facilities. There's a flip side to that. It imposes direct compliance costs in regulated facilities, and it limits competition, which may itself increase costs and limit new competitors with innovative approaches for shaping care delivery. And finally, the last one on the themes that we abstracted here is that CON can encourage a silo perspective on the appropriate role of particular types of facilities as people argue over the boundaries between one type of CON and the next one. That its role, regulation as a tool for quality improvement is limited, and quality improvement objectives that may be better addressed with more appropriate tools. I think Commissioner Thomas, your questions about how do you deal with the bad actors was a very instructive one, because most of the tools that we discussed were actually things that happen after CON has taken place. And you're looking out in the marketplace to say, how are these folks billing? And how are these folks acting in the marketplace? And whatever their intentions were in 1982 when they got their CON, what are they doing today? CON can't help with that. Once you apply and you're done, we're finished with CON, and the bad actors can become, maybe they pull this and they're in, or maybe they are good actors at one time and they change, but the CON is not the best tool for approaching that problem of fraud. And then CON regulation is the primary way for MHCC to implement its objectives for healthcare facility services, and we want to focus on the achievement of the purpose. So, one last slide before we get to the recommendations is that we sort of summarized, I think in July, this is a summary sheet of the problems we'd identified in the first phase, that folks had identified, that the scope of the regulation was outdated, the review processes for handling different types of review were underdeveloped, that not all projects needed the whole review process currently imposed, that the state health plan regulations are in some cases outdated and overly complex. You might think of the ones that don't have an asterisk on the list of state health plan sections we saw that haven't been reviewed in 3 years, and that they need to be better aligned with the evolving all-payer model. The average period of time to review and act on CON applications is too long. That's what we heard consistently, and the period for completeness review before the process kicks off and the initial recommendations is often excessive. Information requirements imposed by CRN regulation are excessive and duplicative. Post-approval performance requirements are outdated and inflexible, and the capability to obtain broader community perspective on products is underdeveloped. Other things that we heard. So going into the recommendation, well, the importance of the three different tracks are really, because we're making proposals to the legislature, we thought it was important to break it down into things that we can do ourselves, things we need the legislature to act on, and then the parking lot for things that probably will need legislative action but aren't really quite ready to be rolled out as a proposal yet. Because we didn't want to lose things that we could act on in that process of developing things for the legislature. So when you think about the regulatory actions that can be started immediately, these recommendations here are not self-acting by themselves. We can recommend that we're going to look at these things to the state legislature, but we will need regulation changes that have details in them. So modernization requires modifications to state health plan chapters and procedural regulations, and the pace of that work will be dependent on including the stakeholders in the specific regulations, developing consensus about how it will work, rewriting the chapters of the state health plan, and we would look at things about obtaining consultants. So it's a conversation we'll need to have with the staff once we get this report out about how exactly do we proceed with the piece that we say that we could do. But we don't need to have the full plan for each one of these recommendations today. And folks will have the opportunity to weigh in on exactly how we are going to do these things at the next stage. Then the statutory changes for the 2019-2020 session, nothing there again is automatic. We need approval from the governor's legislative office with consensus among stakeholders, and the statutory changes will then be followed by a set of regulatory changes to adapt to the new statute. The areas for further study that we've identified, and there may be more as that process goes forward, include removing certain services from the scope of CON regulation. If it's just a gatekeeper function, then maybe it's more of an ongoing licensing issue, and you have to identify the other agency and work out how that transfer would take place. And that some reforms with statutory action may have an impact on sister agencies, such as the Office of Healthcare Quality or the HSCRC. So, with that in mind, the regulations are the ones that we discussed before, and I can go through them. Starting with the ones we have control over, the streamlining SHP standard. And if you have questions or comments, I can stop at any point. Like I said, I feel like I'm going pretty fast. So, nobody is like going, no, slow down. So identify the state health plan chapters that are most in need of updating and which offer the greatest potential to meet reform objectives and prioritize their revision. Doing that will limiting SHP standards to those addressing project needs, project viability, project impact, and applicant qualifications. And if you recall our previous slide, that's leaving out impact on existing providers and leaving out, well, this is the state health plan, so there's another recommendation on the required consideration. Okay. I'm being corrected. You're right. And then applicant qualification standards will allow for the establishment of performance or track record thresholds that must be met to become an applicant, and as such will become the single way which CON regulation addresses quality care as a gatekeeper. Then the second one is to create an abbreviated review projects for certain uncontested projects. And we've listed there changes to better operating room capacity, type or scope of services provided by an existing healthcare facility, expansion of the service area of a home health agency or hospice, or a capital expenditure that exceeds the specified expenditure threshold if the projects are uncontested. The goal there is to limit the completeness review. Remember, that's the initial, we filed an application that's not complete until we get the following pieces of information. Limit that review to one round of questions and responses before we docket it as complete and the process starts. We want that to be a goal rather than an absolute rule, because what can happen is you just accept everything and reject it, right? Instead of doing questions to help them get a docketable, approvable application, you just go in completely the other direction and go, I'm sorry, rejected, not filed, rejected, not filed. We don't want that either. So we would like to try and encourage, let's have one round of review, get things fixed up and get them through the process. But we don't want a hard and fast rule, because it could be just as bad for the customer or our customers as it could be to have a long drawn out completeness process. The issuance of a staff recommendation within 60 days of docketing and final action by the Commission within 120 days of application filing as the other goal. Some of those deadlines will be tied to the Commission's meeting dates as well, right? Remember, at the end of the process, you have to get to the next Commission meeting. So, What would not be eligible for abbreviated review under this proposal would be establishing a new healthcare facility, relocating a healthcare facility, the introduction of services of cardiac surgery or organ transplantation, and contested applications. The recommendation C, revised performance requirements for approved projects that include a deadline for obligating the capital expenditure and initiating construction. What we would propose is timely obligation initiated construction will result in a 12-month extension with subsequent requirements to report progress, and additional 12-month extensions obtainable until project completion. If they don't involve construction, there'll still be a deadline for completing the project, and failure to timely obligate and initiate construction would avoid the CON, so it's not out there. Establish a process for staff review of certain post-approval project changes. So if there are minor changes that don't require commission action, we can have them go through. Budget changes in the physical plan, capital and cost increases, and operating cost increases within limits that we set. And then retaining our approval for changes in the financing mechanism with additional debt, changes in the location or address. Finally, immediate regulatory reform alignment with total cost of care incentives is create the ability to waive docketing requirements or other considerations for approval of the CON for capital projects if the HSCRC endorses the project as a viable approach for reducing the total cost of care under Maryland's total cost of care model. We would retain control over approval of new capacity nursing homes. Home health and others have concerns about the lack of models and inability to serve as conveners. So you heard a couple of comments on this point. I think to think about this here, this is proposed as something within our regulatory power. So when it says waive docketing requirements or other considerations for approval, under this proposal, we wouldn't be able to waive the statutory requirement. And it would leave the regulations that will need to be approved by the commission, the Assistant Attorney General, as meeting the statutory requirement. So as I view this as primarily waiving a docketing requirement, meaning if the HSCRC, as a practical matter, comes to us and they have an initiative under the total cost of care, I personally would prefer not to have a docketing rule that says, that's nice, we're not even going to look at the application. So to me, it's sort of we're not waiving what we're required to decide under the statute at the end of the day, as much as a docketing requirement for the procedural considerations of the proposal. Statutory changes that could be sought in the next session: eliminate or modify capital thresholds, eliminate the capital expenditure threshold used to mandate CON approval for non-hospital health facility projects, limiting the definitions of projects requiring CON approval to categorical projects involving the establishment of facilities or specific types of changes to an existing facility, no matter what capital expenditure is required. Meaning we no longer say you have to come in if you get to a certain dollar amount. Replace existing hospital project capital expenditure thresholds with a requirement that hospitals obtain CON approval for a project with an estimated expenditure that exceeds a specified proportion of annual budgeted revenue. We are not proposing a specific proportion on these. I think partly in the legislative process and discussion will be discussions about what the appropriate percentage of revenue would be. The task force didn't come out with it should be 25%, it should be 50%. But only if the hospital is requesting an adjustment in budgeted revenue based on the increase in capital costs. So they would only need a CON if it exceeds the portion of revenue in terms of size, and they're going to be including it in hospital rates. CON review criteria, future statutory changes, I'm sorry, and this is the one I was referring to before, was limit the required considerations in CON project review to 4 of the 6 requirements. So we're looking at state health plan standards, need, viability of the project, and impact of the project on costs and charges. We're not looking at the impact on other providers because, again, if we're looking at whether there's need for it, then the role of certificate of need, at least in my view, is not to protect the existing providers, but in order to have the needs met. It would eliminate consideration of the cost and effectiveness of alternatives and compliance with the terms and conditions of previous CON. Changes in bed capacity, eliminate the requirement for CON approval of changes in bed capacity by an alcoholism and drug abuse treatment intermediate care facility or residential treatment center. Eliminate the requirement to obtain CON approval of changes in acute psychiatric bed capacity by general acute care or special psychiatric hospital. Eliminate the requirement to obtain CON approval of changes in hospice inpatient bed capacity or establishment of bed capacity by a general hospital. And then for ambulatory surgery, we're proposing to define it as an outpatient surgical center with 3 or more operating rooms rather than 2 or more, which means you can have an ASC of up to 2 rooms. You gain some efficiency that way. Limit the requirement for CON approval of changes in operating room capacity by hospital to the rate-regulated hospital setting, i.e. general hospital. So any person would have the ability under the new definition of ASC to establish 1 or 2 room outpatient surgical centers without CON approval, but with a determination of coverage after a plan review by MHCC staff. Establish deemed approval for uncontested project reviews eligible for an abbreviated project review process if final action by the commission does not occur within 120 days. So this one, if you think about it, currently it's you file it and it gets approved when it gets approved. There's a 120-day deadline, but nothing happens when that passes other than we haven't done our job. This way, if we don't act on it, it becomes approved. You see this in other areas as well. I'm familiar with it in insurance regulation and form filing. And I would say that agencies that have this do not simply sit around and let things become approved. They act with them, within them. I haven't really seen an insurance, a regulator doing insurance forms, for example, that lets the deadline pass and just have things be deemed approved. They look at them and get them approved. And I don't think what would happen here is that we would find that we're just letting things sail through without looking at them as much as it gives us the impetus to take an official action within the time period. The areas for further study are really, I'd say, big ones. That convene a task force with home health, hospice, alcohol and drug treatment, and residential treatment sectors and MDH to look at alternatives to CON regulation, where the real basis that we've heard why we have CON is because we want to keep bad actors out. We want to make sure that the people are not doing it, are not engaged in fraud, are competent, things like that. It's traditionally more of a licensing scheme than it is a CON because need doesn't appear anywhere in that analysis. In which case, one way to do it would be to eliminate CON regulation for those facility categories with MDH incorporating the gatekeeper function into a beefed up licensure process. Or you could establish our role as regulating them only as a gatekeeper, right? Them making us effectively the people who grant the license for whether they're good actors. Either way, I think you're eliminating the considerations that you don't need for a CON. Finally, work with HFCRC to develop an approach in which hospital CON project review and the total cost of care project can be further integrated.
Thank you very much. Paul, do you have anything to add?
Yeah, I'd like to briefly touch on the comments that we heard at the beginning of the meeting. These are not comments that we didn't hear earlier than today. We heard them as part of the task force process of looking at possible solutions to the issues that were identified in phase 1. And we, so we're not, trying to address these on the fly here. They were considered as part of development of our final recommendation. With respect to the comments of the Health Facilities Association of Maryland and Lifespan, Randy did allude to the recommendation on allowing consideration of total cost of care projects that are viewed by the Health Services Cost Review Commission as facilitating reductions in the total cost of care and allowing us to waive docketing rules that might prevent us from considering those kind of projects or other types of standards in our state health plan that might come into play in the review of those projects. I think the concern of these associations with respect to nursing home bed capacity is understandable. This is an area where we have had a long period of time in which population use rates of this service have declined,
bed capacity has declined, occupancy rates have declined, and we do have a very kind of rigid kind of approach to docketing here, where we don't actually accept and consider applications that would add bed capacity, nursing home bed capacity, in jurisdictions where we don't identify need for more capacity, and we don't identify need for more capacity. It's fairly rare where we, when we update our bed need projections, where we have any jurisdictions that have any significant need for more bed capacity. I think, as you were told, we have actually proposed an approach of this kind in the state health plan that's currently out for formal review and comment as proposed regulations. And we have incorporated into that state health plan, we think, some safeguards that are not likely to, have the commission, approving lots of beds under this rule, if any. I think we've emphasized that we would only consider adding new beds for purposes of reducing the total cost of care in areas where it's clearly demonstrated that that's the only approach that is going to give us that advantage. And so we would clearly want to see that existing nursing homes using existing capacity would not be in a position to enter into arrangements with hospitals to reduce the total cost of care. We'd only be looking at adding beds as kind of a last resort. So I don't think this is going to actually be very significant, but we think it's an important thing to an important area where we need some more flexibility as a potential way to address this issue.
Sorry, could you just expand on the we need the more flexibility to expand on this? Because I hear what you're saying, and I've supported that, as you know, in private discussions on this issue. What I'm missing is an understanding of where this is coming from, because it seems like, as we sit here today, we're not sitting in front of any projects that are upheld because of the lack of the capacity to docket in the absence of a defined bed need capacity. We're not seeing TCSC projects come forward that can't come forward because of this, and it's obviously generating a lot of concern in the community. So what are we pushing for here? What do we believe that there is an unmet need that's not out there, that there are projects that are being stalled? Where are we getting the inertia from for this particular clause?
Well, you're certainly not seeing any nursing home projects coming to the commission for a decision that are proposing beds in areas that don't have an identified bed need, because we don't docket them. Right. They can't come forward. And
to hear that they're out there.
Well, basically what we're saying is we actually think that that feature of the way we regulate nursing home bed capacity is something that we should maintain. In other words, we should continue to have what we've had for a long time, which is a docketing rule that says, let's not add more beds in areas unless there's a reasonable forecast that we need more beds. So we want to hold the line in that way. In our proposed regulations, we actually have 3 possible reasons for setting aside that docketing rule and letting a project that would add beds in an area that we haven't identified bed need in. This is one of those where we think it's a project that can only advance the total cost of care model through some changes in bed capacity. This would not necessarily be a new nursing home. This could be an existing facility that wants to expand bed capacity. The second area is a nursing home that's old and needs to replace itself, but it's a small nursing home. And we have encountered this situation in the past few years where allowing a replacement of a nursing home with somewhat larger bed capacity makes the project more feasible. The cost of replacing nursing homes has just outstripped the increases in payment for nursing home care. So that can become a problem when you have a small nursing home that really has an outdated physical plant. They need a larger platform to replace. So that's another area where we would consider waiving the docketing rule. And then another one, which I think is also controversial and is also opposed by the industry, is we've said let's allow docketing in situations where we have quite a few facilities in the area that don't have a very good performance rating under the CMS Nursing Home Compare Star Rating System. So in order to give consumers more choices of better performing facilities, we've also said when most of the facilities in an area are not performing very well, they're 1 or 2 star facilities, let's open up that area to a provider who has a good track record of performing better. And this is a general recommendation. This isn't a recommendation just for nursing home projects. It could apply to any capital project by any type of healthcare facility. It's really in the nursing home area where we've gotten this concern expressed. But again, my experience doesn't suggest that this is something that's going to result in any significant increases in nursing home bed capacity. I would be surprised.
So what on the nursing home side, what I'm hearing in concern is that you've got, for example, one nursing home that is closely aligned with a health system or hospital in some way, and avoids the docketing requirement to request a project that would decrease total cost of care, but there are other nursing homes in the area that may not be as closely aligned, but are capable of delivering that bed capacity. And what we're saying is that we would specifically make sure that that's not the case prior to, make sure that the bed capacity is not already there that could easily be done for that prior to allowing it to occur. But I hear the concern. And what I'm missing on the other side is the example of the project that we're trying to enable, because it's not worth the fight if there's no project there that we're trying to enable.
I mean, is it an academic exercise? Is that your question?
That small piece of it.
Is it an exercise?
It's an attempt to actually have a recommendation that meets the charge from our committee chairs to better align CON regulation with the new payment model. And so we thought this is a way for CON to get out of the way. If there is a conflict between the rules and the processes that we use in Certificate of Need regulation and what they're perceiving as a need to change, to reform the system.
I think that's how, I'm sorry, Commissioner Grady.
I just wanted to say, I view this as sort of building a tool, whether we have an immediate use for it or not. If you're going to get to total cost of care and you're going to actually have some ability to do it, you're going to have these sorts of tools available to you. I think they're putting it forward in a very kind of reasonable, balanced way. But I would hesitate to say, just because you don't have something about to enter this, on the horizon, that we should not build the capacity.
Or at least an example of what might be on the horizon. I mean, I don't see that model for a rational total cost of care reduction model. I don't see that out there as something that's not even imminent or close, or how building more capacity right now is going to do that. And I've supported this thing from the beginning, and the general concept I do support, but I guess I'm wondering, is this real? Is this really going to do anything?
I think for me, looking at it, I think Paul's last point was we've got a charge from the legislature to make sure that we do not get in the way of the total cost of care model. And I would hate for a docketing rule when it does arise to be the commission saying, I know you got this project and the HSC has looked at it and you're really trying to make the total cost of care work. We're not going to actually review it. I mean, it's not that we're going to review it, and if it doesn't meet our standards, we have to deny it, because that's what the statute said. No, good luck with that, but we ain't looking at it. It's not really where I come out on. I'm not a fan of docketing rules in general for that reason. You don't get to do a full evaluation you're supposed to do. I think where there's a recognition that it might be part of the state project, we should give it the full evaluation. This really is the simple level of where I'm at on that, I guess, where I'm coming from.
All right. Commissioner Reimer.
I think the point I'm hearing, we had some comments earlier about, well, the total cost of care hasn't started, but, we got 2 weeks away, right? So it's starting. So I think there has to be some things in place to address what's going to happen. I mean, we kind of all know what is going to happen and what we need to do to meet those requirements. So looking at this nursing home issue that seems to be brought up as some concerns, if you really talk to some of the hospitals, they're going to tell you that's part of some of their challenges is how to get these patients out sooner, how to get them an appropriate level of care, and working with the nursing home. So, maybe this will help us to better develop relationships with nursing homes so we can use them to help us meet those goals. But we also have to be flexible enough to be able to get, some measure of evaluation on whether or not we can expand somehow or allow these hospitals to be able to meet these goals. Because again, the hospitals are going to get the big club on them. And so until we can get to that point where we can really truly look at total cost of care, we have to give them some ability to do that. So I just think, yeah, we're not starting till 1/1 next year, but we better have some tools in place to handle some of these concerns that are going to come up.
Thank you, Commissioner. Any further questions? No further questions? Thank you very much, gentlemen. Thank you very much.
Thank you.
All right. The action now before the commission is to respond to the request of the Maryland Senate Finance Committee and the House Government Operations Committee to produce a report on the modernization of the Maryland Certificate of Need. That is the responsibility we have. So the action before us is the release of this report to the Maryland Senate Finance Committee and the House Committee on Government Operations. Do I have a motion to release the report? Motion. Do I have a second? Second. All right. We have a motion and a second. Is there any further discussion? Any further discussion? All right. Very well. All those in favor of the motion, say aye. Any opposed? Okay, very good. The report will be released to the committees of the Maryland State Legislature. I just want to thank Commissioner Sargent and his fellow task force members for the outstanding job they have done over these past many months. Working through this is a very complex area of public policy. Some of us would like to have seen the Commission go further, but this is nevertheless a very, very good product and a down payment on an improvement of the Certificate of Need process. So thank you all very much. Our next item is an exemption from Certificate of Need, of all things. You know, why do we need reform? Okay. Summit Ambulatory Surgery Center has requested an exemption from CON review to establish a 2 operating ambulatory surgical facility. This will be 2 non-sterile procedure rooms. Kevin McDonald will present the staff recommendation. Oh, Kevin is not here?
No, I'm presenting.
Okay, on behalf of Kevin McDonald, very good, Paul. Thank you very much. Tell us, why should they be exempted?
Yeah, this is a request for an exemption from CON by an existing facility that has 1 operating room. So it was established without a CON because it only has 1 operating room. And they now want to add a 2nd operating room, which then makes them a healthcare facility that's regulated under the Certificate of Need program. This is Summit Surgical Center in Hanover, and it's part of a chain of urologic specialty surgical centers owned and operated by Chesapeake Urology Associates. And it qualifies for an exemption because it is a facility that is owned by a group of practitioners. It's actually the office of some of the Chesapeake Urology physicians. It's where their offices are located, and they do surgery at that site.
This project is very modest in scale. The facility was widely designed to make an expansion from 1 to 2 operating rooms fairly easy to do. They estimate that it will only require an expenditure of about $25,000 to make the necessary renovations and equip what is now used as a non-sterile procedure room as a sterile operating room. They meet our criteria for an exemption of this type because they are fully using their existing operating room at what we have determined to be optimal capacity, of 1,632 hours per year. And they are expanding their surgical practice at this particular location in a way that clearly indicates that they should be able to make good use of the 2 operating room capacity that they're proposing within a fairly short period of time. So this is a project that we actually created an exemption review process for earlier this year. This is the second proposal of this type that we've had, and we feel that this project meets all of the requirements for an exemption review. Prior to January of this year, this would have been a certificate of need application review. The criteria that we established for those types of reviews is very similar to what we're now doing with an exemption, but the idea here is to have a more limited framework of criteria and standards to consider and to be able to bring this forward more quickly. So this request was initially filed in September. It was actually an incomplete filing, and they came up with a more complete filing that addressed all the necessary criteria and standards in November. So we're trying to expedite review of these applications. And you may have noticed that under the recommendations for reforming CON regulation that we just reviewed, this is a project that, if those recommendations are implemented and the statute is changed in the way we're recommending, this type of project would no longer require any sort of review by the Maryland Healthcare Commission, because as long as you're limiting yourself to 2 operating rooms, we're recommending that the new threshold for CON regulation be 3 operating rooms rather than 2. Here with us today is Jennifer Taylor, who is the Vice President for Revenue Cycle for Summit Ambulatory Surgery Centers, and their legal counsel, Margaret Withrop, is also with us. If you have any questions that they can answer.
Welcome, ladies. Very happy to have you. Thank you. Are there any questions for Paul? Any questions for all? No further questions. Well, then I'll entertain a motion to grant an exemption from certificate of need to Summit Ambulatory Surgery Center. Do I have a motion? I have a motion. I have a second. Any further discussion? Okay. All those in favor of granting the exemption, say aye. Are there any opposed? Very good. Okay, they have the exemption. Thank you very, very much, Paul. Thank you. The next item is a change to an approved certificate of need. We have actually have 2 facilities that are asking for the change. Eileen Fleck will present the recommendations on aligning the conditions applied to cardiac surgery programs at Western Maryland Johns Hopkins Suburban Hospital to conform with current statute and the regulations adopted in 2014. The staff recommends that the Commission remove one of the conditions on the 1999 CON issued to Western Maryland Regional Medical Center, and to remove 2 conditions on the 2005 CON issued to Suburban Hospital. So we'll consider action for Western Maryland first, and then the second, we will have 2 votes on this. And the second will be for Suburban Hospital. Eileen?
Good afternoon, Mr.
Thank
Chair.
you, Eileen.
Commissioners. So I'll just provide you with some background information. So a CON was issued in 1999 to Sacred Heart Hospital, which is now known as Western Maryland Regional Medical Center. And in 2005, Suburban Hospital also got a CON to establish its cardiac surgery program. In both cases, those CONs were issued prior to 2012 changes in the statute and changes in 2014 to the regulations for cardiac surgery and PCI services. The CONs for both hospitals address minimum case volume requirements and enforcement of those requirements, and those requirements are not consistent with the regulations for other cardiac surgery programs. So, for example, the current standards in Comar 102417 do not allow the Commission to withdraw the hospital's authority to provide cardiac surgery services based on failure of the hospital to maintain a volume of 200 cases, unless the program is one newly approved that failed to achieve that volume by the end of the second year. So the conditions on both hospitals' CONs are not consistent with that. Those CONs would allow or require the cardiac surgery programs at Suburban Hospital and Western Maryland Regional Medical Center to be closed for failure to continuously maintain a volume of 200 cases or more. So we are recommending that all 10 established cardiac surgery programs be subject to the same requirements with respect to volume and quality, and that's the reason for requesting removal of conditions from the two hospitals. There are copies of the original CONs. I can read the specific conditions if you want.
I don't think that's necessary unless anybody feels on the commission that you should do so. But from my standpoint, no, that's perfectly okay.
Okay. So I think I've given you enough information. I'm happy to answer questions. And at this time,
Sure. Okay. Thank you very much. Any questions from any of the commissioners?
Yes, can I just get a clarification of what the actual issue is? So two of the facilities have dropped below their 200 threshold, and so can you just summarize it again quickly in a little?
So they have conditions that set an expectation for higher volume requirements than we have for the current hospitals, where just based on volume, they wouldn't be subject to consideration for closure or requirement for closure.
I see. So they're held to a higher standard than
Yes.
the others in their field.
I feel like the standard is now 100 cases where there's a concern. If 2 years in a row a program is that low volume, goes below that, then you consider.
Right. But we have
closure.
these two because they're older
Right.
CONs
Right.
that have.
It's basically an establishment of regulatory equity. That's basically what we're dealing with. Yeah. Right. Okay. Yes. Any further questions? Okay. All right. Then I guess the action requested is the removal of conditions of CON for Western Maryland Regional Medical Center. All those, first of all, do we have a motion to do this? Yes, we do. Okay, thank you. And a second? Okay. Any further discussion? Fine. All those in favor, say aye. Any opposed? Okay. The second is a action requested for the removal of conditions of CON for Suburban Hospital.
Well, so there are actually a total of 4 conditions on Suburban,
Okay.
and there are just 2 of the 4 that we're proposing be removed.
Okay, and those 2 are?
So one has to do with if it fails to meet the minimum utilization level annually, then it's required to close its cardiac surgery program. And then the second one has to do with submitting annually within 150 days after the end of the fiscal year, a written report that includes an evaluation of the costs and benefits of the program, which no longer seems useful to us. So that's the 2 for removal. There's a third condition that has to do with outreach to minorities specifically, that was something that was important in the CON decision, where it was a comparative review, and that was one of the reasons Suburban was chosen, because of its pledge to do more outreach related to the minority community.
Did they do that?
They have been. They've been giving us reports, and so we do want to keep that condition. The last one relates to HSCRC and rate regulation, and it really isn't applicable anymore, but at the same time, we don't think it's necessary for this commission to take action on it.
Okay. All right. Okay, very good. Are there any questions at all for Ms. Fleck on this? Yes. Commissioner Thomas.
Just clarification on the outreach. I was here when we discussed that. So So what are you saying? That's under consideration for what we're going to do, or it's not under consideration?
The condition will stay. They still have that expectation.
No change.
No change on that condition. And Ann Langley is here on behalf of Suburban Hospital. Is there any questions you want to direct to her?
Mr. Thomas? Yeah, in fact, we're still getting regular reports on the outreach, right? Okay. All right, if there are no further questions, do I have a motion to approve the removal of conditions on CON for Suburban? I have a motion. Second, Commissioner Hammersbaugh. Okay, all those in favor, say aye. Any opposed? Okay, very good. Thank you very much.
Thank you.
Don't run away. The next item is the long-awaited state health plan change on specialized healthcare services for cardiac surgery and percutaneous coronary intervention services. On September 20th, 2018, the Commission adopted re-proposed regulations, COMAR 10-2417, on cardiac surgery and percutaneous coronary intervention services. Today, Ms. Fleck, who's the Chief of Acute Care Policy and Planning, is going to present the final regulations. Now, if approved, these regulations will go into effect on December 24th, 2018. Is that correct?
I think your decision
Or
officially December 24th.
Got it. I see.
In order to comply with giving AELR.
It's a Christmas
review
Eve
period.
gift. Got it. Okay. Very good. Okay, Elaine, go ahead.
Okay, thank you. So we received comments from two organizations, the Maryland Cardiac Surgery Quality Initiative, which is that consortium of all 10 hospitals, and also the American Heart Association. MCSQI commented that it supports the regulations and specifically supports the change to the Certificate of Ongoing Performance standard related to all-cause 30-day risk-adjusted mortality rates. The change there is to refer to a national benchmark rather than the Maryland average. And so MCSQI was not requesting any change to the regulations. They were simply supporting the changes that are there. The American Heart Association expressed concern about references to the American College of Cardiology's National Cardiovascular Data Registry. They were concerned about being that specific and essentially creating some unforeseen issues if maybe there's a name change or something along those lines, some other change to it. And so they suggested that instead we issue guidance periodically in lieu of being that specific in the regulations referring to that specific registry. And that reference is at several places in the regulations. It's in the standards for certificates of conformance, certificates of ongoing performance, and the definitions. A second concern raised by the American Heart Association is a reference to expert guidelines as of September 2018, which is 0.08C1F. And then there's some questions after that that refer to metrics in the guidelines. It has to do with the external review and the standards that should be applied by those reviewers. And so the American Heart Association requested that the language be reviewed. They didn't request a specific change to it. So on that first issue that was raised, we concluded that the references to the National Cardiovascular Data Registry should be maintained because the name of that registry actually could be changed, we think, fairly timely through amending the regulations, even on an emergency basis if we needed to. And we think that it's helpful to have something specific in the regulations to make it clear to the hospitals and stakeholders the data source that we'll be relying on. On the second issue, the concerns about the phrase expert guidelines as of September 2018, in the subsequent text, we reached out to the leadership, to the two external review organizations that the Commission approved to find out their opinion on this language, and more generally, the section on external review. And they did not indicate any concerns. It was noted by one of them that the criteria for successful PCI are not something that change very often at all, and so there were no concerns about that. It was suggested that we could delete the phrase as of September 2018 to clarify that it is the current regulations that will apply, and we refer to the current regulations, so that change would be a clarification that's a non-substantive change. I also wanted to just add that there were a couple other minor technical corrections. The table of contents, some of the page numbers needed to be altered, and then also near the end of the document, there were a few letters that were there by mistake, just a typo that was actually in the current regulations too. And so that concludes my presentation. I'd like to ask that you adopt final regulations, and I'd be happy to answer any questions.
Okay, fine. Thank you very much. Do we have any questions for Ms. Fleck? Yes. Commissioner Grady.
Thank you. On the idea of the registry, now given that registries are fairly new but kind of quickly changing and evolving, I guess I have some sympathy for a notion of, you know, putting a very specific particular one in the reg that you know, they have kind of monopoly on this now, you have to use them. Certainly heard what you said about we want to be quite clear about what data is being used, et cetera, et cetera. Is there some way to split the baby on that, that it, to a certain degree, say the kind of qualities that we would want in a registry without tying them specifically to the one you mentioned? I guess I'd like to leave them a little more flexibility, given this is it's such an evolving field, and that one of the trends is figuring out ways to get basically industry to pay for much of this rather than it have to be either on the taxpayers or the patients. And so I am a little, you know, in our spirit of flexibility and transparency, I'm just a little concerned to name a specific registry that they have to use or they're in violation.
Well, I mean, we do need to have uniform data collection. We have the authority to do uniform data collection. So actually, initially, we just put a notice in the Maryland Register to require people and let them know they need to participate in this registry as part of what's needed by us to enforce the regulations. So that was initially how it was accomplished, but it's been established for a period of years now. I mean, I think it is something where if it was going to change, it probably does make sense to have a formal review process and that opportunity for comment.
And would we have the ability to make that, to start that process? Is this something, again,
yes,
where we would come back?
Yes.
So if I'm, you know, to consider the Heart Association's concern, if they have a concern that this is really just old technology, they haven't kept up, they have a, you know, they have a monopoly on it, so they haven't really stretched to kind of keep up, and they would like us to consider something, whatever the alternative, their own,
right,
you know, whatever, registry or whatever, then that's something that would go through, again, this sort of a process where we would talk about making a change to the COMAR, et cetera, et cetera.
Well,
so there's an I mean, I hate to just state regulatory monopoly on a particular area that is so critical in such a quickly moving, changing field.
I think that the change could be made fairly quickly. Like, you can do emergency regulations, you can amend it. I think that you could start it like through a Maryland Register notice. You could add to that, and so that could be a second thing they're required to do. But I would probably be reluctant to do that if you are asking for a lot of duplicate information and they have to pay a cost twice. So
gotcha.
So I do think it would be better if you're going to switch that you decide in the regulations and have a process where you talk about it and really consider the implications before then making.
I think that's fine. I'm comfortable with that. I would like it in kind of the record that if this, by granting a monopoly, that this is not a, you know, in perpetuity sort of a thing, that we are open to considering if the American Heart Association would like to come back and say, we would really in 2 years like you to consider this really much better registry, that we are on the record as sort of being open to that and not locked into, you have to go through this one or you're in violation of the law.
Right. Okay. Thanks.
Commissioner, Commissioner Pollack.
Just to that point real quickly, I agree with everything you came through here. I think that if the AHA or some other organization is going to come up with another registry, it's going to take a couple of years before that registry is at the point where it could potentially compete for this type of work. And I think it's also important to understand, in looking at the Heart Association's comments, that they're potentially very conflicted in this, because registries are very big business for these organizations, and they don't want to. The Heart Association wants to see exactly what you were trying to avoid, which is the ACC getting a monopoly on this business right now. Yet for the end user, it's important to know that if you're going to invest in that registry, and that's big dollars in terms of investment, that it's at least a registry that at least for some period of stability is going to conform to what the state's requirements are, and putting it in the regs gives you that level of stability.
Mr. Director,
I think
you've got, okay, fine.
all the points have been made.
Excellent. All right, very good. Commissioner Sargent.
And I just want to confirm, we need, whichever registry it is, we need them to all be using the same registry. It's not a matter of we could have a list of 5 and you pick, we need them to everybody be in the same one with the same data for our purposes.
I think so, yes, for our purposes.
So we might change it in the future, but it would be like we're using this one until this point, and now we're going to switch over to that one. But it's still not we're not excluding people for just because we're excluding them because we want them all in one registry. It's for comparability purposes. Right. Yeah, I just wanted to make sure I understood.
It's appropriate that that level be at the level of a regulatory change as opposed to sub-regulatory guidance, which is what the Heart Association would suggest.
Yeah, I have no problem with those lines. I just want to make sure I understood. Thanks.
Okay, fine. Any further questions? Okay, fine. There being no further questions, we'll move to action on the proposal for final regulations for cardiac surgery and percutaneous coronary intervention. Do I have a motion to approve the regulations final? Commissioner Hayfie has a second? Oh, second. Okay, fine. Any further discussion on the motions? Fine. All those in favor of approving these regulations as final regulations, say aye. Any opposed? Okay, very good. Thank you. Thank you very much, Eileen, for outstanding work in this area.
Thank you.
Okay. Earlier this year, the staff convened a work group to study the feasibility of expanding school-based telehealth services. And the group will issue its report in December of 2019. Work group members encouraged the Commission to establish several school-based telehealth projects to better understand the benefits and the challenges of delivering services to students through telehealth. The staff released an announcement for grant applications on July 11th this year, 2018, for school-based teletherapy for special education. Angela Avant, Division Chief, will present the grant award. Angela?
Hi, thank you. So since 2014, the MATC has awarded over $840,000 to 14 qualifying organizations to implement innovative telehealth projects in the state. Our projects have funded various healthcare settings with different patient populations, targeting different healthcare conditions across geographic regions. We share our lessons learned with stakeholders to help inform the expansion of telehealth in other organizations, as well as to inform our own projects moving forward and fund and future projects throughout the state. As the chair mentioned, in July 11th, we released a funding announcement for school-based teletherapy for special education. We use external reviewers to bring expertise to evaluating proposals that we received. For this one, we had physicians as well as those from Maryland Medicaid evaluate the proposals. The grant was awarded to Charles County Public Schools, and they're aiming to increase access to qualified specialists to provide special services for students in special education. This will be an 18-month project, and they have up to $200,000 based on achieved milestones. The grant will help to inform the work of the school-based telehealth work group, which I believe we briefed the Commission on either last month or previous month. So the Individuals with Disabilities Act of 2004 and Maryland regulations require local schools to provide early intervention, special education, and related services to eligible children and youth with disabilities. Many families and school districts with students with special needs find it difficult to gain access to special care, especially in rural areas. And teletherapy can help assist school districts to provide services to these students with special needs. In addition, students with special needs sometimes have certain conditions that decrease their access to care. That could be needing special accommodations to get to treatment, and even travel can exacerbate some of those conditions. So teletherapy is a way to increase that access. In terms of the project goals, The project will help connect students eligible for special education with a provider who can deliver that special service within the school or where that patient is. We hope to increase knowledge about the benefits and barriers of teletherapy in schools and share some lessons learned as we have in other grants. We also hope that teletherapy will help reduce the stigma associated with in-person special education services, particularly where instruction is provided in groups or where the student is removed from their classroom, especially sort of in those middle and high school schools. We also want to identify potential policy challenges that could be a barrier for school-based teletherapy and hope to develop some policy recommendations to address those. So the project team, unfortunately, since they weren't able to join us today, they had a special project event at the school. But the team will be Melanie Upright, Kelly Bryant, and Roxanne Burlick, who are lead within the Charles County Public School systems as it relates to speech language pathology and special instruction. So in terms of their project, CCPS will utilize a telehealth vendor to provide speech therapy services in accordance with a student's individual education plan or program. This is a team-developed unique plan for students with special needs that outlines the services that will be provided to ensure that they receive appropriate education and education that meets their needs. An instructional assistant will facilitate that teletherapy encounter and will be on site at 4 schools, 2 middle schools and 2 high schools. In addition to services being provided within the schools, students that are receiving either home or hospital-based instruction or part of the extended school year program will also be offered teletherapy. And approximately 77 students will be provided with a service over the grant rate. As we do with all our telehealth grants, staff will work collaboratively with CCPS to identify and collect measures that will help to appropriately evaluate and assess their project. We want to assess whether or not the impact of telehealth is increasing access to services. We want to also assess staff satisfaction as well as parent and student satisfaction with the teletherapy services and outcome measures in terms of progress towards the student's IEP goals. We'll also work with CCPS to develop an achievable sustainability plan to ensure that they can continue the project after the grant funds end. In terms of timeline, we are not going back in time. That's a typo. We'll be launching January 2019. We hope to go live around April. It could be earlier, depending on how quickly they can ramp up. In November of next year, we'll hopefully provide some progress and preliminary outcomes on their project, and then release our final report in the summer of 2020.
Thank you, Angela. I have a job for you.
Oh.
Yeah. You told us that altogether we've awarded telehealth grants to our commission to 14 different organizations, $840,000 worth of grants, a lot of money. And then you said that with these 14 organizations, what we've been trying to do is to glean lessons learned. Then the job is really pretty simple. What I would ask you to do is to send the commission a summary of the lessons learned under 3 categories, only 3. Access to care, cost, if there's any cost reductions in this, and any quality improvements. I know that in previous cases, we've had, you or David, I forget which, we're making presentations on some of these grants. And in the treatment of, for example, diabetes with telehealth, especially for people who are in remote areas, the results were really quite phenomenal in terms of keeping their A1C down. So this is very valuable for us. And I'll tell you this, the reason why I'm asking you to do this is that if you look at the most recent edition of Health Affairs, the entire issue of Health Affairs, which is the premier journal on health policy, is dedicated to telehealth. This is a very big development, I think, in care delivery. It's moving very rapidly and very effectively. I think our commission has actually done a lot of very good work in this area by promoting, this and doing the grant work to, provide some information for both the public and the private sector. So I think if you could just give us a summary of what those lessons we've learned on the basis of this expenditure, that would be very useful, I think, for all the members of the commission. Thank you. Any further questions?
If you would entertain this, I would also like to add to that and I recognize this is probably anecdotal information, you don't have full documentation of it all, but where else, whenever these telehealth grants have proved successful, that we have evidence that other organizations within the state of Maryland have picked it up and are in fact implementing it. I mean, it's one thing for us to prove it's successful, but to be able to then go to the General Assembly and say, it is not only successful, but it's replicable, I think is very important. Say that again? Roger.
And I will say that we keep very close in contact with our past grantees to understand how they sustain their project or even scale their project. And for the most part, a lot of our grantees are thinking about expansion prior to us even ending the project. I know you mentioned some of our past ones in terms of the A1C, and folks are looking at, expanding them to other nursing homes where it's been successful in one or maybe two.
That would be very helpful, if you would entertain that.
I mean, Angela, we don't want to have you working, overtime, but, this is very useful.
To getting all the gathering on.
No, the point is we got to start pulling this stuff together because I'm quite sure an awful lot of people in the state legislature, I mean, if they're following any of this stuff at all, would be very interested to know exactly what the commission has done in this area. Yes, Mr. O'Grady.
So one thing, just thinking about kind of process about how these things move forward, both Health Affairs and the idea of policy recommendations, is we've provided kind of seed money up front. If you want to think of it in a clinical trial, we've done phase one.
Right.
But part of this is, an N of 77. I don't know that that certainly you can't slice and dice into subpopulations. How much of it is rural? How much of this is kids who aren't rural but would have trouble traveling? That sort of thing. So I guess the part of the plan is this is all great work. Is there then, so let's say this one in particular, we get great results, but other than the 77, we can't really take it to the next. Is there, and I know our money may not be involved, but is there then a next step to turn this into something that is of a rigor and power that it gets in Health Affairs, whether we're co-authors or not? We can go back to the Assembly and say, here's how it breaks over 22 Maryland counties, and here it is by race, and here it is by income.
That's an excellent idea.
But that burden of proof, we're on the seed and money end of this business, and so what is the plan, or who do we hand off to get it to that?
Well, I think there's a guy on the commission who sort of just volunteered to write for Health Affairs. I think, but I could be wrong.
Thank you, Randy.
It wasn't me. It wasn't me. I'm taking a break.
Mr. Thomas first, and then the director.
So when you look at the current issue of Health Affairs, you might not be surprised if Maryland's not in there. I think that we're the best kept secret. I think there's just some connectivity issues. So this year I'm chair of the planning committee for the Health Affairs abstracts. I think that's a good first start, and I think the lesson learned idea is a good one. I think the failures are so important. We want to be careful not to overhype this. I was surprised that the outcomes were as robust as they were with how little money they actually had when you spread it out. So we want to be careful not to overhype, but it is the failures, the challenges, how they were overcome That's a story I think that could be competitive in the Health Affairs Conference coming up next year. I'd be glad to help you with that.
Excellent, excellent, excellent. And, Director, you have a comment.
David perhaps wants to expand on this, but keep in mind that this particular project is an offshoot of the telehealth, school-based telehealth initiative. There's been a little rough sledding on that one. There are, when you're talking about telehealth and school-based health clinics, there are a number of challenges here in Maryland, as well as established players in the Department of Education and the Health Department that have perspectives on this. But the motivation for this is to demonstrate results that potentially would, before the final report is delivered, demonstrate some positive results that would break this down. I think all of these suggestions are great. And keep in mind that the commissioners were, I think, prescient because we are, of course, working our strategic priorities report. And one of those priorities is enabling the more rapid diffusion of telehealth. So we're all on the same wavelength. I note that more commissioners have spoken up on this issue than anyone at this meeting. I think that everyone's really riveted onto the possibilities of this. I think there are challenges in certainly demonstrating efficacy and impact on outcomes are really important because we're all swayed by the nifty technologies that are now available. But I think there's really a lot of positive potentials here. I don't know if David, after Commissioner Sargent talks, also wants to add something. But
I guess I wanted to add to people who we may be socializing with, besides the legislature, is particularly the provider community. What we found as a payer is we'll pay for telehealth services. A lot of the providers don't know when to do it. In other words, they have to change their processes, procedures, and having a use case. You should use telehealth when, right? This is when you would use it and how. It's going to help them, as opposed to a market says, now you can do telehealth. So what we found in promoting telehealth with the provider community we have is that they're not quite sure how to integrate that with what they have to do tomorrow. And having some use cases and information packaged that this is where it's worked and this is how we've done it and this is how you might use it would be, I think, an invaluable way to put it out there. And then also I would put Medicaid and CMS in the list of people that we should be communicating these results to. So
that's a good point. David.
Sure. Great conversation. It warms my heart to hear the passion about using health IT. And yes, we're happy to pull together the information the commissioners you've asked us to. But a lot of health IT, and we can pick on telehealth for a moment, is really about demonstrating its value, because there is a reluctance in the provider community in general to adopt health IT unless you're in a big system where you have a lot of IT resources and staff and a budget. So the use cases, the 14 or so that we've put out there, have been wonderful enticers. And can we say that any one of these has spurred hundreds of other, folks, organizations to use the technology? The answer to that is no. But what it does do is it builds awareness when practices are ready to take that next step. And they're being incentivized because if you're participating in the MDPCC program, that is, it's available to, and they're encouraged to use telehealth. If you're participating in MIPS, you're also encouraged to use telehealth. So there's a lot of, and what you heard from Commissioner Sargent is that the payers, private payers, have policies, medical payment policies that foster its use. So what we've been able to do in part is act as a trailblazer, showing that it can work, because practices absent seeing champions in this space will continue to hold the line and not go forward. So we'll show you where there's been some movement forward. But one of the greatest lessons learned, or many of the greatest lessons learned, to Dr. Thomas's point, have been from our failures. And a lot of times people don't want to admit that you make mistakes, but we feel very empowered because of the things we've taken away from projects that have either had glimpses of failures, or one in particular that comes to my mind that just failed, and we ended the grant early, but we learned enormous amount. And you'll see next month, and then I think we'll mention this, we'll be presenting to you one of the lessons learned from the failure prompted us to spend about a year developing a research tool, the telehealth readiness assessment tool, that will allow practices that are interested in adopting telehealth to assess the providers, assess the practices, and assess the patients. And you might say, well, how does that all fit? But what we found, example, in the failures is that the practice was loaded with IT champions, loved their gadgets, loved their mobile devices, but yet couldn't pull it together. They surveyed the patients before they launched the program, and the majority of patients came back and said, we'll use it, we'll use it. And then the practice dynamics looked like it would foster its use, and it failed on all three fronts. So we developed, working with RCI International, a tool that practices can do a self-assessment, get a sense of a score for how ready are they, and then included lots of academic learning lessons based on the literature that will help them move forward. So I could talk a lot longer, but I know you all don't have the endurance to listen to me go on and on about health IT. But I'll stop there and just give you that sense of what's coming down the pipe. But Mr. Chairman, thank you for the opportunity.
Oh, absolutely. Now, this is, I think I'm really, just from the 14 examples, and, your point about, learning from failure is really the key principle here. Everybody who's been in the private sector who's had to take risks knows that's the foundation of success.
Right.
Taking a risk, failing, getting back up, and doing a better job, and then winning. And sometimes winning really big.
Yeah.
So, okay. Well, thank you very, very much. Okay. All right. Mr. Director, could you tell us about upcoming initiatives for the January public meeting?
So before I do that, I wanted to be sure that we thank the staff and our consultants on the CON modernization report. That included Paul, Kevin, Sue Ellen, Linda. We have some of our representatives from BRG here as well. That was a daunting effort, and we appreciate all of that work. I also want to recognize Janet Ennis, who's gone today, but we closed out our SOCIO grant this past month. This was a rate review. 2 grants we had with SOCIO that ended in December. As Janet hiding here in the back. Yes. What I think that the story will come out, federal government slow, that Maryland was one of the success stories of this, where the cost was the funding for some of the where the cost efforts came from SOCIO's rate review money. I will note without comment that actually the MIA returned its rate review money earlier in the process because they couldn't figure out necessarily how to use it. But the MHCC spent every dollar and spent it, I think, very wisely. And Janet was a very careful guardian in meeting all of the federal requirements on that. Our team with David in terms of getting the telehealth efforts, especially in school-based work, are going to yield fruit, even if we have to plow through some of the resistance. Teresa didn't get to talk today, but she did. Stay tuned for those videos. You saw them last month, and if you see a movie, I think after the first of the year, there may be a public service announcement regarding the quality site. Let us know, if people are pulling out their phones, even though there's admonitions against doing that at movies, to check out our site. And we're really excited about everything we're doing moving forward. Certainly the next steps in CON. David and I have opportunities. We'll be meeting with some of the leadership at the Office of the National Coordinator to talk about what we're doing, as well as figure out if there's ways that we can work with And to the point about telehealth, we'll be meeting with the Primary Care Coalition, which is doing some very interesting collaborative work with hospitals and nursing homes in Montgomery County on telehealth, and there'll be opportunities to really collaborate on that as well. Turning to the meeting, we will have the readiness tool demonstration. I think we'll plan to do that. Megan, who's not here, will finally have an opportunity to review this mobile integrated health EMS effort that we're doing with NIMS, in which we're charged with finding some funding frameworks for continuing these innovative EMS programs. It's going to be I think a report that really captures where things are, which is not exactly where we want it to be for the next couple of years. We'll review the legislative process that we follow here at the Commission. Some of you have been around before, know it. A couple of you who have not will hear it for the first time. We try to be collaborative, and as I said, Tressa will have a video ready to go to show you, but it actually is going to be rolling out before the Commission meeting. So if you really want to see it, check out a couple movies in the time over the next couple weeks, and hopefully see that. So I'm being prompted for something, but I don't know what that is. But oh, of course, the reception is next door. The cookies, you didn't get cookies now at lunch, but they're now available.
Okay. But before, first of all, are there any questions of the director about what's going to happen next month? Okay, good. But before we go to the cookies, we have to have a motion to adjourn. It's kind of required. So have a motion, have a second. All those in favor say aye. Aye. All right. We are adjourned. Thank you. It wouldn't be adjourned. It was